Do you want me to start?
Not just yet. Hang on. Admit the waiting room.
Yeah.
We're recording.
Cool.
Just give it 30 seconds.
Yeah, of course. Yeah.
As people enter.
Yeah.
But maybe do a bit of chat now.
Right. Hello. Whilst everybody spills from the waiting room into the actual webinar, I'm just saying hello. We're really pleased to see so many of you here today. We had almost 300 people sign up, I think. So we obviously get a bit of a dropout, but we're thinking we're going to probably have over 100 people join us, which is wonderful on this grey Tuesday afternoon. And we're going to talk obviously about people's experiences of waiting. Could hardly be more topical. Okay, I think I'll get going. Is that all right? Welcome, everyone. My name is Charlotte. I'm Chief Executive of National Voices, and I'm really pleased to see so many of you here today. We will hear about work that a project manager partner, Sam Hudson from Urology, did for us sort of during the spring and summer, talking to people's experiences of waiting for health and care services. This work was commissioned by NHS England as part of the clinical review of standards at the end of last year. And then the people we were working with in NHS England and us were kind of trying to repurpose and pivot the work to give it a bit of a COVID angle, but we're obviously talking about people's experiences of waiting before and after COVID. And we're very grateful for the flexibility colleagues from NHS England showed so that we could kind of capture what's going on right now. We have a stellar lineup for a panel. We've got really interesting speakers. Professor Helen Stokes-Lampard is going to talk about her experience as a doctor and health professional. Shiva from the King's Fund is going to talk about the wider perspective, the numbers. And then we've got Rachel Burnham, who is managing the recovery of elective care at Guy's and St Thomas's Foundation Trust. And we've just in the chat before this said she is the owner of the largest waiting list in the whole of England, the proud owner. Okay, before we get going with the actual report, and Sam is giving a quick presentation about that, I'm handing over to another Sam, who is a colleague at National Voices, who's going to do a very short technology briefing. Many of you would have seen this before and will have by now be very familiar with webinar technology, but he's going to very briefly whiz through that.
Morning, afternoon, everyone. My name's Sam. I'm the Communications Officer at National Voices. Just going to quickly run you through the tech. Just before I begin, just want to let everyone know that we are now currently recording this, and it will be available later this afternoon on our YouTube channel, and we will circulate the link with you all later. As a sort of basic guide to Zoom, if you haven't used it before, the bottom left of your screen, you've got options to control whether your video is on. Today we are going to be meeting all attendees, and we would like you to contribute in the chat, which some of you already started messaging in. To launch the chat, you hit the speech icon at the bottom of your screen, and if you could go there and introduce yourself, where you're from, that'd be great, and just so you can get used to it, because that's where most of our questions and insights are going to be put today. The other bit I want to mention is that on Zoom you can control how you view your screen. So if you have it on full screen or on this one, as you see here, where you have the chat alongside, it's totally up to you. And that option is up in the top right hand of your screen. So yeah, that's a really quick crash course on Zoom. If you've got any questions, please feel free to email me on the email address on the screen now, or privately message me on Zoom, and I'll hand it back to Charlotte.
Thank you. So Sam, if you show us what we're going to cover today. Right, so we're going to hear from Sam Hudson, who's Director of Urology, and she will talk about the work she did on our behalf. And then we will have a very short contribution from a participant in the actual listening exercise, Lindsay. She wasn't sure whether she was well enough to actually attend today. She's suffering quite badly at the moment, and so she recorded herself. So we're going to have a very short film from her, and then we're going to move into the panel discussion, and I'll ask the three panelists for a short reaction to what they've just heard from their respective perspectives. And then we're going to open it up to the floor, and we've got people from charities, we've got members of National Voices, we've got people from NHS trusts, we've got academics, and we've got a lot of health watchers. Welcome to you all. Okay, Sam, are you ready? And if you are, then please take it away.
I am. Thank you, Charlotte. I guess, first of all, I'd like to, and we'll probably do this a few times this afternoon, but I don't think we can do it too many times at all, is say a huge thank you to the people who took part in this work. They were incredibly generous, not only with their time, but also with telling their stories, which were often, really tough to tell. And also to National Voices members across the community and voluntary sector, who were great, first of all, at finding people who could take part in the listening exercise, but also in sharing their existing evidence and information and insights that they had, which were incredibly useful. So yes, we were asked by NHS England and Improvement to do this, and we really wanted to understand what it was like to wait for a range of different types of care for the people concerned, but also their families and the people around them, their carers as well. Next slide, please, Sam. So we started with some desk research, and we were delighted that Care Opinion and the Patient Experience Library were able to help us with that. And that gave us the themes that we could then use for the interviews. As you can imagine, pre-COVID, we were planning co-design workshops across the country, and we quickly flipped these to one-on-one phone calls. And actually it worked really well because we were able to really focus our attention on the individuals. And we had a fantastic mix of people who were waiting for all different kinds of things across the country, and at lots of different points within a health journey. So it gave us a really good broad picture. And from that, we've been able to produce a report that describes that experience, so kind of reflects it back, but also goes a bit further and tries to offer some practical ideas about how we can actually improve things. Next slide. I think it's safe to say that we can say with absolute confidence that a poorly managed wait has an impact on people. And it's quite complex, but ultimately it's about uncertainty. So people talked about feeling helpless, being in limbo, not being able to plan. And the impact of this, not only on their physical health and their mental health, I mean, the shadow fell quite far. It was impacting on people's working lives, their employment, being able to plan ahead and keep their employers up to date. Sometimes housing, relationships, there were all kinds of impacts for people not knowing what was going to happen to them. And quite often people had multiple waits. So they'd either had lots of waits leading up to the wait that they were now having for diagnostics and different types of procedures. But many of the people I spoke to were kind of balancing, they were waiting for more than one thing. And there was a sense that they were fighting the system. So they were the cog in the wheel of this wait, and they knew not only about their own condition, but about all the different parts of the system that they were having to navigate. And a lot of people talked about having to almost psych themselves up for the next interaction and kind of gather together the energy to make that call and to try and find out what was happening next, and trying to get services to communicate with each other. And really at the root of this was the uncertainty that they all felt. Next slide, please. So we wanted to understand what this was like during COVID as well. And actually, if you imagine the kind of core problem being uncertainty, and then kind of add the additional layer of the uncertainty that COVID brings for all of us, it's really just intensified the experience. So the themes were the same, but they were being felt more keenly. And I would say everyone I spoke to was at absolute pains to say that they understand the delays that the system is under. They respect them. They completely appreciate what the NHS has been doing this year and previously, of course. And there was a lot of kind of positive thoughts about the NHS, and people were extremely grateful. But in that, whilst that was happening, they also felt that they had some very immediate things, and often quite small things, that would have made a huge difference to their daily lives. But they didn't want to be an additional burden on the service. There were some positives as well that people talked about, and in particular, the interactions with GPs. A number of people had proactive phone calls from their GPs, GPs getting in touch and asking them how they were, and they really appreciated that. But also the charity and voluntary sector, people found that the support provided by things like helplines, people doing online videos to help people with self-management, they really appreciated that stuff. And even though they'd had to kind of hunt around for it, they were really grateful that it was there. Next slide, please. So we've been able to make a number of recommendations, and we've kind of pulled them into 3 themes. So the first is really understanding the importance of the experience from the people who use your services. Obviously, patient-centered information and communication, and then having a kind of menu of support, either direct offers, but also being able to signpost people to where support is available. Next slide, please. And really, it's about asking people. So finding out what it's like to wait for your service, but also what's it like to be referred from your service. And there are a number of things that people felt could really help them. So obviously information, knowing what it's like, what the wait is potentially going to be like. And we appreciate, and it'd be really interesting to hear what the panel say about this, we appreciate that this is going to be really hard, but people just wanted something that would tell them how long they might have to wait, what might influence those waiting times, and what might cause things to change over time. What to expect from the procedure or the appointment. People were quite often in the dark about where they'd been referred to, but also what that would involve once they got there, and they were really, thirsty for that kind of information. People wanted to be able to make decisions and to share those decisions with the people in the system, and there was a real sense that a number of people felt that they weren't being listened to, and some people described waiting for things that they knew they didn't really need. It was almost as though they were having to kind of jump through a few hoops to get to the thing that they really needed, and they knew that they didn't need these things in between, but they felt helpless to try and kind of communicate that and to try and change the system, I guess, or to try and work with the system. And there's some really straightforward things around self-management, around physiotherapy, pain management, mental health, knowing who to contact when your symptoms get worse, knowing what to look out for, etc. And of course, the opportunities that are offered by virtual healthcare as well, which people, despite the health inequalities we know and the barriers for some people around virtual healthcare, that was actually felt to be, at the moment, a really crucial alternative to in-person appointments. So that just about covers it. After this call, we will of course release the report, and you will all be sent a copy so that you can release the link so you can download a copy. And I'm now going to hand over to Sam, who's going to play a short excerpt of a film that one of our participants has made, which describes a little bit more her reaction to the report and also her experiences. So thank you very much.
Thank you, Sam. I can feel my anxiety rising. Multimedia on a webinar. There we go.
I'd like to start by thanking Sam and the team for inviting me to speak today, and also for undertaking this hugely important piece of research. On reading the report, I was struck by just how many of us feel the same sense of isolation. So there was a great sadness at reading these shared stories, but also a validation of my own feelings. So I think it's really positive that this research has been commissioned and now published, and I hope that on the back of it, changes can be implemented and improvements made for patients. it was interesting to think about my own experience of waiting due to COVID disruptions, because as an endometriosis patient, I am constantly waiting for answers. I waited 15 years for a diagnosis. I've been waiting 30 years to find out how this disease is affecting my body and different organs. I wait every month for the pain to come back. And I've waited time and time again in A&E, only to be told that they can't see anything wrong with me because I have an invisible disease which can't be seen on scans. So, you know, living with uncertainty and constantly waiting for answers is a huge part of living with endometriosis, and this has a big impact on our mental health and creates a lot of anxiety. So I do feel like I have the experience to talk about this. In terms of how it affected me, 2 weeks before my planned hysterectomy in April, it was cancelled due to COVID, and I think it's fair to say that this was really devastating for me, because it had taken a lot of courage and contemplation to make this decision. As a 41-year-old woman who hasn't had children, I hadn't made this decision lightly, and I was willing to go through with a hysterectomy in order to try and regain some of my life, which has been overtaken by the pain of endometriosis. Even though hysterectomy is not a cure for endometriosis, I was willing to take this risk. So mentally preparing for surgery any surgery is difficult. Mentally preparing for a hysterectomy when you haven't had children had taken a long time to find peace with. So to have this pulled away from me at the very last minute was incredibly hard to accept. And I think what made me feel even more sad was just this there was no recognition from anyone about how I might feel about this. And then when things did start up again, I was told that my surgeon was shielding, so I would have to go on the back of another surgeon's waiting list. So to this day, I'm still waiting to go onto a waiting list. At the same time, I was also having investigations into my lungs thought to be caused by endometriosis. I've been having various symptoms. So this all kind of went on hold as well. So it's taken a year, and 3 weeks ago I had a lung resection to remove abnormalities from my lungs. And last week I was due to get the results of the biopsy, but this has now been delayed by another 6 weeks because they have sent the biopsy to a different pathologist to get a second opinion, because they believe that I have a very rare form of lung disease, which is either a primary condition in itself or has been caused by old endometriosis in my lungs, which has created some scarring. So I think, you know, not only do things need to urgently improve for people with endometriosis, but it's also really important to recognise the pain and anguish which is caused by the waiting process for all patients. Feelings of isolation and worry due to the uncertainty of it all can become quite overwhelming, especially when this is compounded with pain. You know, and so I think this in turn, and also when you are made to feel like you've been forgotten in the system because no one's communicating with you, you begin to feel a bit worthless, like you're not important. And you also have to become a bit of a project manager to make sure that different departments are speaking to each other, and to make sure that you're still in the system, because it feels like you have just been forgotten. So waiting has a huge impact on our mental health. I think living with uncertainty is incredibly difficult and shouldn't be underestimated. And I think it's really important that patients are given access to decent pain relief, physiotherapy, psychotherapy, anything that, you know, can help them and would be beneficial during this difficult time. And I think the importance of clear, regular communication from the healthcare provider is vital.
Thank you, Lindsay. I don't know whether you are actually joining us on the call today. I forgot to say earlier when I roll called the people who are on this call that we have actually quite a few of the participants from our engagement project joining us today. I feel particularly honoured that you do that. Before we open the floor to all your questions and ideas and thoughts and comments, and I saw some of those already coming in response to Lindsay's words, powerful words, I I'm going to ask our very esteemed panelists to say a few words. And I'll start with Helen Stokes-Lampard, who, as well as a jobbing GP, also chairs the Academy of Medical Royal Colleges. And we asked her to give us her reflections on what this might mean, all this insight and those recommendations for doctors in particular. Helen, over to you.
Thank you, Charlotte. Can I just confirm you can hear me?
Yeah.
Yeah, excellent. Okay, it's always that uncertainty, isn't it, on Zoom?
Yeah.
So thank you, Charlotte, personally, and all the brilliant team at National Voices for this really powerful launch. It's very special, and I think trying to react too directly what Lindsay has just said kind of risks undermining it. She spoke so articulate and so heartfelt. So I'm going to take a deep breath. I'm going to kind of reflect a little bit more widely on the situation, but I think a lot of this is going to come up in the questioning. You asked me, Charlotte, to give a slight overview of some of the areas where the worlds I touch are thinking about this stuff. And so I'm, as you said, I'm a GP by profession. That's my first thing. I'm an academic, but I'm also chair of the Academy of Medical Royal Colleges, which is a body that brings together every different medical discipline. And we aim to achieve consensus on standards of care, on education, career progression for doctors, but also we speak out on behalf of them on issues that affect us all. And I wear another hat. I'm chair of the board of a new charity, which is the National Academy for Social Prescribing. And social prescribing is something we're going to make a noise about it, help people understand what it is. But the aim of social prescribing is to enable everyone to live their best life, irrespective of their medical needs. And we think of it as a social revolution in healthcare, something that's complementary to, not separate from, what we do in the NHS. But the work we're sort of, I guess, celebrating today, I think we have to frame everything in terms of this COVID-tinged world that we find ourselves in. When novel coronavirus came into the world, it changed forever. It changed our world. I guess it amplified the problems where inequity and social determinants of health have an even more tangible, visible and immediate impact on survival from an infection. And I'm going to suggest we don't use the term post-COVID. There's a lot of popularity with that. There's not going to be a post-COVID world. It's going to be a new normal where COVID is just part of our lives. We'll survive the pandemic, so we can talk about post-pandemic, but everything we do has to be adapted. And in a sense, this work today is so much more important because although it was commissioned before we had the pandemic, its importance has just escalated, and I know others will talk about that. So the Academy of Medical Royal Colleges, I use sustainability as a term that brings together what we try and do. Sustainability of our planet, of course, as citizens, we all have responsibility. And let's face it, environmental challenges are far greater threat to us all than COVID actually is. But core to our purpose as an academy is the sustainability of medical careers and making sure doctors are the best they can be. But relevant to today, and thirdly, is the sustainability of our NHS in the 4 nations of the UK. And again, a lot of what we're talking about today is directly relevant to NHS in England, but the principles apply universally. My particular interest is the 4 nations of the UK. And I want us all to have a comprehensive, state-funded, universal healthcare system that will endure for at least another 70 years. And so I think we've got to radically rethink healthcare and the way we deliver it. And so I believe that we have to start with the person in their own social and domestic situation, empowered to live their best, healthiest and most rewarding life, based in an environment that supports healthy, sustainable living. So that's communities, local government, employment, and all those factors that we know impact on health inequality, so that when people do need advice about their health or well-being, they're informed, they know where to go, and they're supported and enabled in an accurate, timely way with personalised information at their fingertips in a way that's right for them. And so when there are medical issues, to the point at which we call people patients, or they step into the medical world, if you like, healthcare entry point is clear and unambiguous and easy to navigate. And as we've already heard, navigation of the system, I love that phrase, I wrote it down, about being a project manager for your own health. But that shouldn't have to be the way the patients project manage their own health. And I want a healthcare system where people remain considered as a whole person with views and opinions which are shaped by their life course. And when then things get serious medically, the system responds to these, communicates seamlessly with the patient and within itself, because communication within the system is a huge challenge, and does what it needs to do while remembering the whole person within it. So people aren't treated in body parts or single diseases for longer than we have to. And this concept is what I call rethinking medicine, starting with the person, not the institution. Now, of course, to most of us on this call, this isn't radical, it's common sense. And you get it, it ties beautifully with why we're here today. But actually it flips the way that our current structures are set up. And so much of what Lindsay referred to is systemic, the way we're set up to work. It's not that people in the system don't care about patients, far from it. It's what our raison d'etre is patients and caring for them. But actually the systems that we work with need to be radically rethought. So I think we need to ensure that care takes place where the people and their carers should understand what they should and shouldn't be able to expect. We are on a journey with our patients, not institutions. And so it's a practical, accessible way forward. So I'm just going to finish about, I'm a GP and on a daily basis. I'm in practice yesterday, and I see the pain and harm that comes to people who feel abandoned on waiting lists. I feel their pain, I share their frustration, and one of my roles as a GP is to help improve the system one patient at a time. But what we're all doing here has the potential to improve communication at a whole scale level. If people feel valid, if we communicate better and work with our patients, and if people feel they're included as part of the process, they will get so much more out of their care. And in turn, they'll be our greatest allies to fight for an NHS for the future. So I'm going to stop there. I think I've had my 5 minutes, but I'm really looking forward to the discussion. Thanks.
Thank you so much, Helen. Always good to listen to you. Rather than doing questions right now, we're going to do all the contributions from the panel. So the next expert we asked to join us today is Shiva Anandachiva from the King's Fund, who is their chief analyst. So I think that means he crunches their numbers, or he crunches the numbers on behalf of the King's Fund. And, you know, there have been quite a few numbers about waiting. So I'm hoping, Shiva, you will enlighten us as to where do these experiences we've heard from today fit into the picture as you see it? Over to you.
Great, thank you, Charlotte. So as Charlotte said, I was asked to provide some context on what the national picture looks like, particularly around waits for planned care. So in my 5 minutes, I'd like to do three things. First of all, talk about what the numbers show. Secondly, talk about what the numbers don't show. And finally, talk about where next. So in terms of what the numbers show, the number that is probably talked about most in national circles around waits for planned care is the 18 weeks target. There's promise in the NHS constitution that from the point of referral to the point where you get definitive consultant-led care, you shouldn't wait more than 18 weeks. And the target is 92% of people being seen in 18 weeks. And I think it's not the only important target, but I think it's worth talking about, partly because of the history that this was set up under New Labour. So we have nearly 20 years of history and familiarity with the target is talked about in national circles. And secondly, because so much of the way the health system is set up was geared around this target. We changed the way hospitals were paid. We changed the entire performance management culture. New providers of services entered the market simply to help achieve this target. So a huge amount of emphasis was put around it. So if that's the target, how many people are waiting and how long are they waiting for? You know as well as I do, it's not a good picture. As of August this year, there were 4.2 million people on the waiting list for planned care. And if the target is for 92% of people to be seen within 18 weeks, where the NHS is currently operating at 54%. And probably the one number that leaps out more than any to me is the number of people waiting over a year for care. The target is 0. Yeah, this is meant to be anathema that anyone waits more than a year for care. At the last count, 111,000 people have been waiting over a year for care. And this is excluding organizations that for one reason or another don't report national figures. So that's the first bit, what the numbers tell us. Unfortunately, what the numbers don't tell us is probably even bigger. So I said there are 4.2 million people on the waiting list. That number, the size of the waiting list, is probably as unhelpful at this point as at any point since it was developed, because as you know, people aren't being referred at the same rate. So there's this big bulge of unmet need, unmet demand that isn't even appearing on the waiting list. So yeah. At this point in time, I'd say it's not as important to focus on the size of the waiting list, it's how quickly people are getting put on and taken off the list by treatment. The second thing is, once you get past a year of care nationally, it's a little bit unclear exactly how long you've been waiting, which just speaks to how much of a rare event it was meant to be. So we haven't really geared our system around incredibly long waits beyond a year of care. The third thing the numbers don't tell us And I had a conversation with a GP where, to be honest, I felt like a bit of a muppet 2 weeks ago, because I ended up saying a sentence like, oh, sorry, I was talking about official statistics on how long people are waiting for care. You're talking about how long people are actually waiting for care, because it was back to Sam's point about the multiple waits. You wait for diagnostics, you wait to even get onto the referral pathway, and then you've got to wait that, as we've just heard, can last up to a year. And the fourth and final thing about what the numbers don't tell us, and why reports like this are so important, is what is the impact emotionally, but even clinically, on these waits. And if you get a chance, I'd go back to in June 2019, the Public Accounts Committee in the House of Parliament did a report on waits for care. And as part of the evidence session, they asked national clinical leaders, you wait 18 weeks for care. What's the difference of 18 weeks versus 19 weeks versus 20 versus 52? And clinically, nationally, the answer was broadly, we don't know. So the third and final thing I wanted to talk about is where next. I think the honest truth is waits are going to get worse. I know that sounds banal, but activity is already being cancelled in hospitals to prepare for COVID, so we can do less activity. And when you can do activity, it's going to take longer. The donning and doffing of personal protective equipment adds time to surgeries, for example. So that's point one. Point two is there is innovation going on. The health and care service is not standing still. Virtual working, planning activity on a regional level, keeping some sites dedicated just for planned operations while others are dealing with emergencies. All of this is good stuff, but unfortunately, I think it won't be enough to stem the tide of rising demand. And the pressure on services will not go away. We may not see hospitals doing as much activity, but that simply means that people like Helen are going to see more patients who need care and need more complex care. So to finish, I think, where do we go from here? The first one is obviously not to take planned care off the agenda. That we're heading into winter, there'll be a big focus on emergency care, understandably, but we need to make sure treatment levels are as high as possible. Secondly, where possible, let's not over-medicalize. So social prescribing, as Helen's talked about, trying to meet the whole needs of the person, making that part of the offer of our health and care service in this country. And the third one is recognition that this is a serious problem. People talk a lot about hips and knees as if it's an inconvenience. Not getting an intervention can sometimes be the difference between you living in constant pain or not, as we heard from Lindsay. It can be the difference between you being the person you want to be or not. So this is, I think the stakes are higher than we sometimes allow ourselves to believe from the numbers. And the final thing I'll say is, linking back to this report, we need to get better at the experience of waiting. I think there's so many good questions in the report, but this question of, do you know what it's like to wait if you're running a service, is fundamental. And I see some organizations that absolutely get it, walk the pathway alongside patients, do deep work to try and understand what it means, and put effort into explaining decisions, saying this is what's going to happen and why. And other organizations where, if I'm being honest, the attitude is much more, times are tough, you take what you're given. And I think we all want to be that first organization, or at least be treated by them. So I think there's a question we can come to later of how do we learn from the best, which is important even before COVID came along. So thank you for the opportunity, Charlotte, and I'll hand back over to you now.
Thank you. That was so interesting and so clear. I was sort of worried that we hadn't given you slides to talk to and that it was all going to be a bit difficult to follow, but it was really very clear. Thank you so much. Rachel, over to you. Rachel is in charge of rescuing elective care or improving elective care or recurring elective care at Guy's and St Thomas's Hospital in South East London, or Central London, really. It's the one right in Westminster and by London Bridge, you might know it. Rachel, over to you.
Thank you very much, Charlotte, and quite some acts to follow there, particularly given that I'm going to speak from an acute trust perspective. So I'm conscious that a lot of the things that have been identified in this report are for us to action quite urgently as well, in terms of how we improve, as you said, Shiva, that experience of waiting for care. And as someone with a particularly large waiting list who is genuinely and quite rightly losing sleep over what we do about it and how we improve it, I just wanted to share, I think, 3 of my key reflections, having read the report and being reflecting quite considerably on this over recent weeks, as we, particularly in London at the moment, have that period of trying to do as much as we can before what we imagine will be a second wave, and trying to preserve as much elective activity as we possibly can. So my first reflection is that actually, as an NHS manager, of which we have very few on this webinar, but I think that probably says something in itself, we need to move from thinking our job is just managing our waiting list and trying to treat more patients more quickly, to actually understanding, as you've rightly just challenged, Eva, the experience of whilst you're waiting. And I must confess that I've absolutely been someone who's fallen into that trap in the past, which is that we feel that we're in an acute trust, we must treat the patients, and we must treat more patients and treat them more quickly. Actually, I don't think we feel enough responsibility, and Helen alluded to what she sees in her practice, for that period of whilst you're waiting, that actually you're still, or you should feel, under our care. So that's something that I definitely think we need to take away and improve. What I liked about the report when people are able to read it this afternoon is it suggests some quite practical things, and I'm going to focus on what they are, because actually I feel that I could implement some of them fairly quickly, and I'd like us to push nationally for all trusts to do that as well. So the first thing is that we need to change what we view our job is in terms of managing waiting lists. It's managing the wait as well as managing the patients being seen and when they're being seen. It made me quite sad actually in the report that patients are grateful for care, because you shouldn't have to be grateful for being seen, and we definitely had that when we restarted our elective care here. Actually, that's us providing the national service that we should provide. It should actually really resonate with us that people are grateful for getting their knee replaced or whatever it might be. So firstly, I want us to be thoughtful about how we can improve and take responsibility for that experience of waiting. And secondly, I think to communicate what we are doing as an acute trust whilst you are waiting. And I think we're terrible at sharing information, and that's too much of a big action for us to take as this group, and it's such a truism in the NHS. So actually what I quite liked, Sam, about the work that you set out and that slide that you showed with some of the key recommendations is actually there's just a few simple things we can do. Let's not improve how the NHS overall shares information, because none of us will live to see that, I'm sure. But actually, at the point of referral, can we automate a letter or a text that says, hi, I've got your referral, our average wait is 6 weeks to first be seen. So just some key points where actually we could challenge ourselves. In this point in the pathway, we can actually share information in a more meaningful way. So that's my second point, really, I think, which is the recognition that we need to have as acute trusts and as managers and as clinicians in acute trusts, that our patients are starved of information. A few weeks ago, I ran, for bizarre reasons that I won't share with all the webinar, I ran a self-swabbing clinic for patients before they had their operation to swab for COVID. And every patient that I met, and I was running that clinic and it was a weekend, asked me loads of questions about their procedure. And that's just because they'd met someone that they thought might be able to answer them. But clearly that information is not available on our website. It's not come through in their letters. It's not been available through their clinical conversations. And that's something that we urgently need to get better at. We're starving patients of information. So there's something I'm reflecting on there about how much of this stuff can we make available, both locally, but also nationally, because many of these things are similar across the board. So we could do it once and do it properly. And then finally, I was reflecting on, there's a bit of a culture of shame, or there's very much a culture of shame about waiting lists in the NHS. So the numbers that Shiva was just saying, I'm really ashamed of my waiting list. I'm ashamed that I've got patients who've waited for over a year for their care. And I know that my consultants feel the same. And it's quite a shameful thing that if you're a surgeon, you've got a waiting list and it's 18 weeks long, or it's however long it might be. And that has led to us not sharing information about it, which actually one of the key things we could really take away nationally, but certainly locally, is to say, hello, you've just joined my orthopedic waiting list. My wait for an operation is currently 19 weeks. And it just sets that expectation management. So we need to get rid of the shame. The information, given that she was able to quote it, is available nationally, but we hide it so that only chief analysts at the Kingsman can actually go into it and understand what it means. But actually, why can't you type in Guy's and St Thomas's, which I did, by the way, on Google yesterday, average wait currently for first appointment in outpatients, and find out what it is, so that you can plan your life around it, even if it means that I'm really embarrassed. Well, quite right, so I should be. So there's something about that culture of shame that we have in NHS and secrecy about waiting lists. And actually, I think there's some really easy actions we could take. And I'd love that to be national, but equally, I'll try and champion it here, to share that information so that people can plan their lives, but also so that we can improve and be embarrassed, hopefully, to improve the situation. So those were my slightly rambling thoughts as an NHS manager responsible for a large amount of waiting.
Thank you so much, Rachel. That was so interesting and really deep, I think. I think you took that really way beyond the operational challenge, because it is a cultural challenge, and there is also, as you say, there's a sort of emotional challenge there, isn't there, to stop denying this reality that people have. I really appreciate where you've taken that. I remember Rachel very early on in her career is working with Jamaki at NHS Improvement, and even thinking then, she's going to go far. So everybody here on this call, keep an eye out for Rachel. She'll go places. And she'll do so for the benefit of patients, which is wonderful. So we have had loads of discussion online on the chat from people. I'm going to ask Sam to tell me who we should take to the panel first.
Yeah, thanks, Charlotte. So, I mean, you would have all been watching the chat as the people were chatting. Talking. People were really grateful for Lindsay's film, and actually there was a great quote in it, which was "waiting to go on a waiting list," which is pretty powerful. And there was some discussion about patient-centered care and co-production and how to really make that a kind of meaningful reality. So a couple of questions. One was about staff involvement. So Jill Dyson said, turning the question around, how do the staff who are involved feel? Do they feel that they've got good communication pathways with the patient and not recognising patient needs? And is it a question of a patient needing more current information, and how will this best be carried out? And a couple of other people asked similar questions about do the staff involved really understand what people's needs are in this context? So there's a couple more, but should we start there?
Yeah, definitely. And maybe I'll ask Rachel and Helen to sort of come back on that point. Rachel, maybe ask you first. In your experience, because you obviously kind of at the interface, aren't you, between various clinical teams and the managerial staff and also patients, what do people see in their different roles, and how could we improve that, and how could we support staff to see more of the reality that patients live with in their respective roles? Have you got any thoughts on that?
Yeah, I think partly it's the disconnect between what generally happens, which is an administrative member of our team will speak to patients, try and book them in for the next appointment, or will be the person that picks up the phone when you eventually find the telephone number to be able to call us, versus the clinicians responsible for their waiting list having reviewed them. And I think actually what we don't do very well, so for example, on my waiting list for surgery at Guy's and St Thomas's, which has got, Shiva will tell you the exact number, but there's a large amount of people on it. Every single one of those patients has been reviewed by their clinician, has been assigned a priority according to their latest imaging, their notes, whatever it might be. And what we haven't done is communicate that to our patients, which is clearly, it would appear to a group such as this one to be quite nonsensical. And yet actually you'll speak to an admin member of staff who will say you're on the list and just assure you that at least you've not gone missing. So I think it's the disconnect between actually clinicians who are certainly during the first peak of COVID went through every single patient on their waiting list, reviewed them, didn't call them as often as they might have done, but actually tried to at least liaise, speak to the GP, etc. And what you feel as a patient, which is not aware of the fact that any of that has happened, no idea that you've been prioritised. And actually, why don't we try and respect our patients a little bit more and say, do you know what, you've been assigned a priority that we deem it's clinically appropriate that you could wait up to or beyond 3 months for this procedure. Yeah. And then intelligence and say, that's not right, I'm deteriorating, whatever. So I don't think we've got the connection right between the work that's going on to review and check where patients are in the waiting list and letting them know about it, and so that you don't ever feel that work's happening. I'm not sure if I've quite answered the question, but that was
very much really interesting point. And I think it would be massively reassuring for a patient to know that the severity of your case has been discussed and that you have been deprioritized or prioritized. And even if you don't want to be deprioritized and wait longer, it means, you know, you're not one of the poor people who's even more desperately ill. You know, people can get their head around that. I think that's a really good point. Helen, have you got any thoughts on how we could support staff to engage with this more meaningfully in a way that's more productive?
So I'd like to sort of break, there's a few bits here, and I'm very struck by what has just been said about the sort of the admin versus clinician divide. There's that gulf between the administrators who do one set of jobs, the clinicians who are doing another. And I'm going to divide clinicians into the sort of the first point of contact care, so the community or the A&E clinicians, versus those who are the sort of the second point of care, whether that's planned care or even if it's urgent, you know, surgical opinion or whatever. And there is quite an important difference. So you tend to find the front line, the first point of contact clinicians are really live to this stuff. So whether it's the nurse in the GP surgery, whether it's the junior doctor in A&E, whether it's the paramedic, they hear it, they feel it, and often a significant amount of time is taken up with a patient expressing anger and frustration at what's led to this moment. And so they're very live to it, but often lacking the power to do anything about it. Then you get the administrators, and our hospital administrators and secretaries are amazing and take so much hassle in the same way GP surgery receptionists and things do as well, because they get people phoning up and the vast majority of the time people are signposted to the wrong person. So they don't have access to the information the patient wants and needs because our IT systems aren't joined up. In the same way, you know, as a GP, I don't know if my patients in secondary care have been prioritised or what the priority is. You know, I'm as in the dark as they are. But and the secondary care clinicians, of course, are so pigeonholed into the boxes of time of what they're doing that there is no space in the system. But it doesn't have to be that way. We can change the system. And Charlotte and I have been on some really interesting working groups recently trying to help change the system. So as we reprioritise the waiting list, particularly we're thinking about diagnostic tests at the moment, and how we can bring some of this in and this communication be better. And I think one thing people don't understand, and how we should share this with people, is that the fact that the NHS computer systems are so broken up and in bits, but probably the most comprehensive bit of it is the GP record, and how we can get the message out to patients, please sign on for access to your own record, because at least then you can see what I can see as a GP. You know, you may be disappointed with what little I can see, or you may be amazed that I can see this stuff about you, I don't know, but at least it's the honesty about, if you don't sign up for it, you're there. Now, of course, that brings in a whole second conversation about those who are not able to access the technology, the digital divides and all the inequality stuff. But for those who can, at least there is something there which can help a bit. So there's lots of points we can pull out of that. So I'll stop because I think there's so many good questions here.
Brilliant. Shiva, you wanted to come in there.
Yeah, if that's all right, Charlotte, I just wanted to say 2 or 3 things very quickly. The first one is on staff. A lot of the staff I speak to feel crap about this. And I know, pardon my crudeness, but that's the word that came up, because I was talking to an ophthalmic surgeon, an eye surgeon, and he was saying, I trained, you know, the taxpayer trained me to do this job. It's what I love doing. I turn up for work every day to find out my surgical list has been cancelled because we have emergency patients. So he was saying he feels like his purpose in life is being devalued as well. Yeah. So it's you know, there's multiple angles to this. The second thing is there is a huge cultural divide in how organizations approach this. There are some organizations where you walk in and the surgeon would say, that isn't my job. I treat the people who are brought to me when they hit my table. I'm afraid, sorry, what you're talking about is not my job. If I went to work for Rachel, suddenly I'm in a culture where you manage the wait, you treat the person, you don't just do the episode of care. And so there's got to be some mechanism where the poorer performers can learn from that. And probably one of the biggest differences I've seen is places like Leeds, places like Barking, where they put in, it's called a lean management, but basically it's just trying to work from what adds value to the patient or the person, work backwards from that, and then have a really systematic way of seeing where you can reduce waste. And I think what that's done is given people this learning culture, this impetus to do things better rather than just accepting, well, this is the way it's always been and the way it always will be. So I think there's something about supporting staff with tools to help them learn and putting the right culture around that.
That's interesting. Rachel, what are your thoughts on sideways spread? You know, like, we're obviously really impressed with how you're thinking, you know, as a whole person about the people that you're dealing with as whole people. So what are the mechanisms that would enable some of your working practices and some of your thoughtfulness to travel across to other hospital teams, or do those mechanisms not exist? And is there a role National Voices could play? Have you got any thoughts on that?
I think that, as you'll recall from the fun we had about 5 years ago with Jim Mackey on this for NHS Improvement, sideways spread is not our best strength as an NHS. And I should say that I'm very sure that of the 200 participants on this call, someone will be on one of my waiting lists and having a poor experience. And in which case, obviously, write to me, but also it's definitely not, you know, none of us are getting this right at the moment. But my thought is that actually, especially with the influence of this report and the fact that I was really pleased to see that NHS England and Improvement had commissioned it, actually there's nothing better than putting some information out in the open to make people's behaviour change and respond to it. So actually, in my mind, a couple of really quick, easy things we could do is share the length of wait for first appointment and for surgery in different specialties at all hospitals. That information exists, it's publicly available, it's just not easily digestible from a patient perspective. So that, and then also to implement, and I can't see why we couldn't do a push on this and certainly try and make some progress, given that more patients are waiting for longer than ever they have before, on those key points of communication at the key points of the patient pathway. So has your referral been received? Are you being booked for an appointment? Have you been referred to another specialty? I think two key simple things like that we could try and push on nationally might really help in terms of spread. And then some things follow, because once you start thinking about it, you realise the other processes you've got in place that aren't very patient friendly, and you hopefully from there would improve or not. So I don't think we're very good at spreading practice, but I think sometimes you can do a bit of top-down work to try and push things along.
So maybe it's a good moment then to mention that we are really delighted that that NHS England was enlightened enough to say, let's find out about people's experiences of waiting. And it was at the time when the review of clinical standards, or clinical review of standards, I think, was set up. But also that since then, we've had many conversations with people right now who are trying to keep elective care going throughout the second wave. And one of the things we've decided to do was that we set up a little working group that looks at what Pauline called something like a minimum information offer. And, you know, part of me is a bit cynical about stuff like that. And I think, oh my God, it's another box to tick. And you could just see how the NHS is going to hit that target and miss that point, because, you know, we excel at that. But part of me also thinks some of this is just very practical, like you've just said, acknowledge receipt of a referral. And so we are working up a sort of commitment that NHS England want to take to all the hospital trusts, that they will need to write to everybody who is waiting with a minimum set of information, which includes who is in charge, how to get hold of that person or their team, how long you are likely to have to wait, or when you are going to hear again, because sometimes, you know, if you're just entering the Liverpool COVID tunnel, you might not know when you can do operations again, but you could commit to being in contact again at some point, what alternative sources of information and support are around, and what to do if things deteriorate. So I think, you know, let's be hopeful about this. Let's give it our best shot to see whether we can get services to, in a way, signal to people that they are caring for them. Because I think that is what I've heard, zooming right out from the interviews that Sam Hudson has done, is that people feel like no one's caring for them, when actually they are in a relationship with a hospital, with a provider of care, and that just because you can't have your eye surgery or you can't have your knee replacement right now doesn't mean that you're no longer in a relationship. So let's signal that to people. And maybe that is one of the steps that we can take towards culture change, because I sometimes think when we talk about flipping the system and changing the culture, it's like, well, what are you supposed to do with that as a hospital manager? Whereas if we keep it really practical, we might make some progress. So it's really great that NHS England are committing to trying to figure this out with us. And I think tomorrow evening or the day after that, Helen, you are also on that meeting. We have another meeting where we try to nail down what that actually could look like, a minimum offer that we commit to everyone who is waiting and will be waiting. Sam Hudson, what questions have come up in the chat? We've got time for maybe one more.
Yes, okay, so there's some really good, I mean, there's lots of observations in the chat as well, so we will try and save those actually so that we can share them. I guess what's quite interesting, so Vicky Enser has said that there are not very many waiting times within mental health. There's not a full set of waiting time standards. And then David, who's a patient public voice representative, said that a significant number of people who are waiting for treatment will also be waiting for adult services. And, you know, how can we take the opportunity to take these ideas to that kind of wider integrated care picture as well?
Okay, right. I'm going to invite my panel to reflect on those final points very briefly before we wrap up. Maybe we start with Helen. Do you want to start again?
Oh, okay, thank you. I'm not going to talk too long about it. I've been looking at quite a lot of the comments, and they're really powerful, and they're echoing a lot of what's in the report, just rephrased. So the issues for me about, you know, feeling valued, knowing, the concept of a relationship, you know, a two-way relationship that is for duration. Some of the stuff I'd said about patient records has brought out frustration with people that either the record, they can't access it at all because they're not in England, so it's not even an option to them. That's an England initiative. When they can access it, it's imperfect, and yes, it's being rolled out and it's being improved. And that when they can access it in hospital, that sometimes comprehensive records aren't there. It's a very superficial thing, and that's mostly technological. So the tech will catch up, but there is something about the inequity and the patchiness of what's there is frustrating, which makes it hard to communicate at national level. So even if we can, and I think we actually should push for minimum standards of what people can expect, it's still not going to happen overnight. But again, if we're honest about what's happening and when it's going to happen, people want that. So honesty, transparency, and well, I won't speak for any of the others on the panel. I'll let them do that for themselves. But thank you all. Really powerful session.
Shiva, brief last thoughts from you.
I suppose two brief last thoughts. The first is, despite the terror of COVID, there's some opportunities here from system working. So all around the country, systems are looking outwards more than I've seen in the past 10 years. So rather than taking an organization focus, a service focus of this is what I do, really starting the conversation of, if we've got all these people around the table who can deliver services, do we really understand what our people need from us? So I think there's some opportunities to hold on to. The second thing is back to the practicality. If I was working in a service provider, I'd probably think, have I taken every opportunity to do things better? And there are places like Milton Keynes where they changed how they do outpatient bookings. So it's like booking a gym appointment now, or a gym session. You can tell I don't go to the gym very often, but the patient controls the process. And internally, they went through a whole difficult conversation of control over power, over choice. And ultimately, it was not the hospital who decides when the patient can turn up. It's for the patient to decide when it's convenient for them. And you know what? They saw attendance rates go up, not down, fewer missed appointments for consultants, and people were happier in the hospital and the patient. So I think anything that shifts that choice and control towards patients away from services can only be a good thing.
Thank you. Really powerful last thoughts, and important, I think, for us to hang on to the opportunities that arise out of this real difficult situation we're in. Okay, Rachel, last but not least, what are you taking away?
I think what I'm going to choose to do, because often in my current situation, you can get quite overwhelmed by poor systems, IT, waiting lists, second wave of COVID, and instead, I'm making a public commitment, so you can all follow up on it with me afterwards and check I do it. I think I'm just going to take some of the really simple things that I think we can action both locally, and then I'd like to try and influence with everyone else's support to do it nationally, about communicating at key points in the pathway, removing some of the secrecy and stigma of waiting time so that people know what they can expect, and also crucially what you're doing about it. So the fact that you are reviewing people, that you're trying to reduce your backlog, and some of those actions that we tend to keep in private board minutes, that actually patients have got absolutely every right to understand what we're doing, and it's our responsibility to inform them. So those are my personal commitments from a Guys and St Thomas's perspective, and I look forward to having a follow-up webinar where you can check that I've done some stuff.
Wonderful. Well, you are now on our books, so we will come back to you. Right, it just remains to me really to say thank you. Thank you to Sam Hudson from Urology, who's run this project for us beautifully and thoughtfully. Thank you to NHS England, who financed this work. Without that, it wouldn't have happened. You know, we are a very precariously financed organisation. Thank you to our members who put us through to people and also let us understand what they already know about weights. And the point that someone in the chat just made about mental health is a really strong one, because our mental health colleagues, for example, said targets would be really powerful. Thank you to Care Opinion and Patient Experience Library, who let us see their evidence and let us analyse it. And last but not least, thank you to all of you who took part in the research, and some of you are on this call. I hope you feel like we've done justice to what you have told us. Thank you to everyone who took part this lunchtime and took time out from their busy schedules to learn what we've learned. Let's make things better for people. That's what we're here to do. All right, stay in touch, and we will be in touch with the report and all the other collateral. Speak soon. Bye-bye.
Thanks, Charlotte. I'll see you tomorrow.
Yes, bye-bye.